Thank you very much. And once again, thank you for the invitation for this great meeting and great faculty. So, considering the new trends, looking at what we can do with the PSI is mandatory. So these are my different disclosures. So we know, and for a long time, that total shoulder arthroplasty and reverse shoulder arthroplasty getting more and more popular procedures. But we know also that the glenoid is the weakest point of the construct, of the structure. And we also know that the component malpositioning is the main etiological factors for glenoid failures. So, raised the patient-specific instrumentation to optimize the implant placement, and this was, for the last decade, seems to be the best evolution to get an ideal positioning of the implants. What is already known, it has been said largely just before, that the 3D analysis is much more accurate than the 2D analysis of the different elements. It's now known that this 3D analysis and planning is mandatory before doing the surgery. But what about the long-term results and the complication rates? We also know that it's related to the implant positioning mainly. So the other question, on the other hand, we know that with this PSI, if we consider the preoperative planning, then the sending to the manufacturer, then getting the PSI and doing the surgery, it increased the time before the surgery, during the surgery, it also increased the expense. So we know also that the PSIs improve component positioning on X-rays, but we don't really know what the clinical outcomes will be because it's something that we developed only in the last decade. So we don't exactly know the impact of the PSI on the survivorship curves. So now I will give you a lot of data through different articles. So one of the first one was to evaluate this PSI versus conventional instruments on 20 fresh frozen shoulders. The problem was that these cadaveric shoulders has no real deformity. So the conclusion of this paper was that if you look at the difference in inclination between what was planned and the final results for the inclination and the version, the only things brought by the PSI was that it reduces the variability in the component positioning, but for normal shoulders. The second one is a clinical one. Only 20 patients, 10 anatomic total shoulder and 10 reversed shoulders. The mean deviation in glenoid version, once again, between what was planned and the results, was less than 2 degrees. And the glenoid inclination was 1.3 degrees. And the guide insertion was quite in the same position that was preoperatively planned. But the problem was that in this paper, we have no ideas on the structural defect of the glenoid preoperatively. So we are most of in the same configuration with the cadaveric study. We had just osteoarthritis, glenoid, without posterior defect or other defects. So it's hard to bring in the front the really help of this PSI. Another study with just a small cohort of patients, 11, 7 total shoulder, 4 reversed. The advantage of this paper is that look at the the version of the glenoid, they use the PSI for real deformity of the glenoid. They also compare what was planned and the results, and they found that there was 0 degree inversion, and the objective was to have 0 degree inversion and 10 degrees of inferior field. The mean deviation was 8 degrees for the total shoulder and 10 degrees for the reverse shoulder arthroplasty. And look at the data of the deviation is quite high because it's 10 degrees in both for the version in both group, and the inclination was 1 degree of variation, plus or minus 4 degrees for the total shoulder, and 1 degree plus or 5 degrees for the reversed. So they also looked at the cases that was considered as outliers, more than 10 degrees of difference between the planning and the results, and 5 out the 11 cases were considered as outliers. So they said, conclusion is that the PSI for total shoulder arthroplasty is not as accurate as it puts in. But once again, in this study, the patient had large defects. Then I will show you 2 systematic review and meta-analysis. The first one in 2018 put together 12 studies, 227 patients. That means 7 studies and of patients and 5 studies on cadaveric shoulders. The deviation, once again, from the prior planning and the results was in favor of the use of PSI, with a good restoration for the version, inclination, and for the entry point of the guide. But the accuracy was also in favor of the PSI, but the difference between the 2 groups was less than 5 degrees. And we still don't know if you put together the error of measurement and the error due to the reconstruction in the planning, if these 5 degrees are not in the error of measurements. But it's still in favor of the PSI. The second meta-analysis, published in 2019, there was a lot of paper considered, 45, but after the different exclusion, only 7 can be included in the study. For 718 total shoulder arthroplasty, mostly anatomic versus reversed. The mean posterior error was, postoperative error was in around 5 degrees or less in 20 papers published. The meta-analysis found no statistical difference between the PSI and the normal or the standard instrumentation for correcting version, inclination, and positional offsets. And moreover, there's no difference between, and if you consider these 5 degrees, we don't know what are the long-term clinical benefits to correct or to have a difference of 5 degrees. So right now that was the science. My personal opinion is that the 3D preoperative planning is mandatory, as it has been explained just before. That's mandatory. I don't think that we can or we should or we also can afford to have a systematic PSI for the standard cases. But for revision or specific cases with large deformation, we may use this one. But to use properly a PSI, we do properly what we routinely do. So we need to train with normal configuration to have a reliable surgical technique when we do specific cases. So sometimes we have to use this PSI until now. But the future is probably the augmented reality, and we will have a great talk right after about this. I don't use it. It's not routinely used till now. So the conclusion is that there's no real difference between PSI and standard instrumentation, but the planification is mandatory. We don't exactly know the advantage to have a difference of less than 5 degrees in the two groups for the long-term outcome of our patients. We know that there's an impact on the operating room time, the cost effectiveness, and for this, we think that all this information is needed to say or to really infer that the PSI is the gold standard. Thank you, and I invite you all in for the next SFA meeting in Toulouse next December. Thank you.